So we are going to discuss about the neuromuscular blockers, and my topic is their mechanism of action. So now, once we come to the neuromuscular blockers, we basically understand what are the drugs which are acting on the neuromuscular junction and the ganglions. So prior to that, I want to discuss some anatomy of it. So a very warm welcome to all of you. So I think we should start. Okay. Okay. So prior to that, I want you guys to understand what neuromuscular junction is. So the neuromuscular junction, it connects the nervous system to the muscular system, and this connection is via snaps. So snaps is a gap. So basically, our nerves are not straight wires; they have a gaps, connecting gaps. Uh, f when we go to the neuromuscular junction, we basically discuss about the connection between the nerve and the muscle. So this neuromuscular junction, it will connect the nervous system to the muscular system through a synapse, uh, which is between nerve fibers and the between afferent nerve fibers, so the motor nerve fibers and the muscle fibers. So it comprises of a motor neuron, that means any neuron which gives the uh, action potential, and it's composed of an end plate, motor end plate. Formed between the plate and the motor neuron is a synaptic cleft or a junctional gap which divides them. Now, what is a motor neuron? So, motor neuron has the function of controlling skeletal muscle activity. Anatomically, it originates in the ventral horn of the spinal cord. The axons of all the motor neurons are surrounded by myelin sheath, and a single motor neuron can connect to several skeletal muscle fibers. So as the motor neuron enters a muscle, as the motor neuron enters a muscle, the axon divides into small dendria, telodendria, जिनके ends जो होते हैं, the terminal buttons. Uh, so this motor neuron enters a muscle, so axon will got divided into 10. जो उनके terminal buttons होते हैं, they connect with the synapse, and within the synapse, they will connect with the motor. Now, what happens in the junctional gap? There is the release of the neurotransmitter. When I am talking about skeletal muscles, so I'm usually going to talk about acetylcholine. So the release of neurotransmitter or acetylcholine occurs with the consequent binding of the receptors, that is nicotinic acetylcholine receptors. So this is where we have discussed it in a picture format. So this is a presynaptic terminal. You can see this is a presynaptic terminal. These are synaptic vesicles filled with the neurotransmitter. This is a synaptic cleft, and then this is the postsynaptic membrane. This neurotransmitter which is accumulated in the synaptic vesicles after the action potential influx of calcium, it gets into the synaptic cleft and then finally to the postsynaptic membrane. Now, when we talk about the acetylcholine, we talk about different receptors, and here the main receptors which are important for me are the nicotinic acetylcholine receptors. They mediate the neurotransmission postsynaptically, that is after the synapse at the neuromuscular junction. The primary receptor is the nicotinic acetylcholine receptor. So it's called nicotinic because it is stimulated by the neurotransmitter acetylcholine, and it is also stimulated by alkaloid nicotine. So this nicotine, it's because whenever we talk about the cholinergic system, we go to two main receptors. One is the muscarinic ones, and one are the nicotinic ones. So they actually are named because of the fact that their actions are more or less the actions produced by an alkaloid muscarine and by an alkaloid nicotine. Now, this is what we have explained in the physiology. It's a graphic representation. So, broadly, we divide the nicotinic receptors into two groups. One is the nicotinic N1 or nicotinic muscular. They are present in the nicotinic neuromuscular junction. Second are the N2 receptors, or we call them as nicotinic neuronal receptors. They are present in autonomic ganglia, CNS, and adrenal medulla. Now, I'm before I get down to the neuromuscular blockers, I will discuss the transmission at the neuromuscular junction. So it is basic physiology. It happens. There is a depolarization by the action potential, and when there is a depolarization, uh, that means the action. Usually, we consider that the neuron is having a negative potential. So after an action potential, the neuron's potential rises, gets negative from negative to zero and to some positive values. I have forgotten the values, but anyways, uh, when there is the depolarization, the depolarization, persistent depolarization or depolarization, it causes the action potential to travel down the nerve fiber to the neuromuscular junction. So once it travels to the neuromuscular junction, uh, there the axon terminals, they cause the influx of calcium. So when there is influx of calcium, so the synaptic vesicles, because the neurotransmitter is not present open, it's present in the synaptic vesicles. So the influx of calcium causes the fusion of these synaptic vesicles to the membrane, and finally the vesicles release the neurotransmitter, for example, acetylcholine. So it is more or less same with other neurotransmitters as well, except GABA or something. But with acetylcholine, the MOA is like that. Then this acetylcholine diffuses across the synaptic cleft. It will bind to the postsynaptic, that is, which is present beyond the synapse, acetylcholine receptor, which is located at the muscle fiber and at the motor end plates. Now, once the acetylcholine once the acetylcholine binds to the receptor, it will open the membrane channels, uh, followed by the subsequent influx of sodium and outflux of potassium. And this is what a simple sodium potassium pump does within a neuronal membrane. And this change in voltage is termed as the motor end plate potential. So the motor end plate will come at a different potential. So once this threshold potential is reached, the postsynaptic action potential is generated, and that postsynaptic action potential is propagated over the entire cell membrane. Okay. So the kind of an neurotransmitter which is unbound in the synaptic cleft, it will diffuse away or it's hydrolyzed by acetylcholinesterase. So basically, uh, whenever any neurotransmitter is released, there are three different actions which happen. One is once a neurotransmitter is released, majority of it is taken back, which is called as reuptake. Some of it goes and binds to the receptors to produce a subsequent pharmacokinetic or physiological response. Third one is the one which is not bound, which is unbound. So that unbound neurotransmitter is degraded by specific enzymes. In case of acetylcholine, it's degraded by acetylcholine esterases. So this is a neuromuscular induction. So this is basic physiology. We need not to explain it. Now, once we come to the neuromuscular blockers, we usually classify them in two categories. Basically, what we mean by neuromuscular blockers, they are the drugs which relax the skeletal muscles and they act at the neuromuscular junction. So there are two types. One is the non-depolarizing blockers, and second one is the depolarizing blockers. The non-depolarizing agents, they are competitive antagonists, so that they compete for the neurotransmitter. So they cause the competitive blockade of the NM junction or the neuromuscular junction. So it is, in the layman's term, it is a kind of a race against the usual neurotransmitter. So we collectively can tell that this neuromuscular blocker is having affinity towards the receptor the same as that of the neurotransmitter, but with an efficacy of 0. So that means it uh, competes with a natural neurotransmitter. In case of acetylcholine, it's acetylcholine. So it competes for that. It prevents its binding to the neuromuscular receptor and then subsequent depolarization of the motor end plate. So this is the acetylcholine here. So you can see acetylcholine tries to bind, but in case of acetylcholine, we put a molecule called tuberculorin. It binds to this. So there is a competitive kind of a blockade, competitive block. So because of this competitive nature, there is an advantage that we can relieve this kind of blockade by increasing the usual levels of neurotransmitter at the synaptic rate. How you can increase it? You can use any kind of a cholinesterase inhibitor. So to reverse its effect, definitely you have to increase the neurotransmitter. So once the neurotransmitter increase, it will subsequently try to take the position of the receptor and displace away the blocker. So we can use any kind of an acetylcholinesterase inhibitor. So the prototype of non-depolarizing blockers is panacurinium, galamine, mevacurinium, atracurinium, rocurinium. So they are all having a competitive blockade action towards the acetylcholine. Now, therapeutic use, they are used as adjuvants. So they are not primary drugs. In surgical anesthesia, we use them as adjuvants. They should be given by parenteral route because they are poorly absorbed. They do not cross the blood-brain barrier except atracurinium that crosses the blood-brain barrier. So it can cause seizures also. The adverse effect is it can trigger a histamine release, so there is a chance of anaphylaxis. It can cause hypotension, decrease, and it can also cause bronchospasms. And there is an allergic or skin wheals. Now we talk about the depolarizing agents. So the depolarizing agents are the ones which mimic the actions of acetylcholine. So they are cholinomimetics. So, but they're not the usual cholinomimetics like neostigmine, pyridostigmine. They have a different action. So the only one used is succinylcholine. So what it does basically, it causes the muscle contractions, very rigorous ones. It causes excessive depolarization of the motor plate, and then that excessive stimulation causes tachyphylaxis and finally causes the paralysis of the muscle. So its advantage is that it has an onset of action of 60 seconds. So now we talk about MOE. So it's very important. There are two phases: phase one block and phase two block. Phase one block is it will the succinylcholine which is used. It opens the channels, so it will react with the nicotinic uh, receptors, and once it reacts with them, it starts opening the channels and increasing the ionic conductance. So what will it do? It will cause the excessive depolarization of the motor end plate. That means the motor end plate will get excessively depolarized. So, and it has an what I call, it is not the huge like the usual cholinomimetics. It has an advantage because succinylcholine, it is not metabolized by any kind of a cholinesterase enzyme. So that means it, uh, except for the fact that once we give it by the parenteral route, it can get metabolized within the plasma. That is, plasma cholinesterase can inhibit it, can metabolize it, but in the synapse, it is not metabolized. So it will remain within the synapse, and the depolarization will persist, and the body will not get the nerve cell will not get repolarized, and it will also prevent further depolarization of the uh, neuronal cell. Then there is phase two block, which we call as the desensitization. So end plate will eventually repolarize, but since succinylcholine is not metabolized like acetylcholine, so it will continue to occupy the acetylcholine receptors, and finally it will desensitize, because after a certain age there will be desensitization of the receptor, so which will directly do a therapeutic action will be the muscle motor and plate will be paralyzed. So we can increase their blocking effects by acetylcholine stress inhibitors. So because they have a similar action that to that of an acetylcholine. Now therapeutic use, they're also used as adjuvants in surgical anesthesia. Their pharmacokinetics duration of action is short. Why? Because within the plasma they can be degraded. So that's why they are given as CRI, constant rate infusion. The adverse effects is when we give it with gaseous anesthesia halothane. The people with some genetic predisposition, they can experience malignant hypothermia. It is a kind of an allergic reaction, but it is more or less genetic, but it is an allergic reaction towards certain anesthetics, usually gaseous anesthetics, which can cause the increased amount of temperature in the body and followed by muscle spasticity. Uh, Also, any adverse effect is increased intragastric pressure, causing MSS and muscle pain. So we can discuss it. It is a life-threatening clinical storm. There is hypermetabolism, including the skeletal muscle. So it is probably when we use halothane with a skeletal muscle relaxant succinylcholine or a depolarizing neuromuscular blocker. It's not allergy usually. It's caused talked about as allergy in the usual therapeutic clinical practice, but it is more or less an inherited disorder in humans and in pigs. So this is a mechanism, but I don't think it's here pertinent to mention it. But yeah, uh, peripherally you can understand that there is a kind of a receptor called the ryanodine receptor in skeletal muscle. It is abnormal in the people, and this abnormality interferes with the aggregation of calcium in the muscle. So that abnormal ryanodine receptor that controls the calcium release, it causes a buildup of calcium in skeletal muscle, which triggers a massive metabolic reaction that leads to increased temperature. So hypermetabolism causes increased carbon dioxide production, accelerated oxygen consumption, heat production, and activate of both sympathetic and parasympathetic nervous system and multi-organ failure. The treatment is you have to wrap the patient in a cooling blanket to reduce the fever and risk of serious complications. The only drug used as of now, which is known as an antidote, is the dantrolene. So we use dantrolene as an antidote. So it corrects the severe muscle spasms also. And we also correct hypothermia and organ dysfunction. Now we use cholinesterase inhibitors. These are drugs which inhibit the action of cholinesterase, the enzymes which hydrolyze acetylcholine in the synapse. So they have mechanism of action and they inhibit cholinesterases, neostigmine. So the therapeutic uses of antidote for non-depolarizing blockers because they block the action of acetylcholine. So we can use them by increasing acetylcholine. In myasthenia gravis, we use neostigmine, and we also use it as a diagnosis for myasthenia gravis. The drug is edrophone. I think we are done with the part of muscular blockers.